We have a quorum, Ms. Beanie.
Excellent. Okay. Shall we go ahead and get started then? Is that the thumbs up? Okay. Well, Happy New Year. I hope it doesn't feel like a repeat of last year for anyone. It sure feels like the saddle's well worn. Really grateful to be here with all of you today. And I want to start off with asking for a little grace as I kind of get my groove on, taking the big shoes of Rick Trelevin and walking them forward. So want to welcome you all to the Health Council meeting, and we will go ahead with, shall we do introductions, Donna? Should we do that first? And then I have a few comments that I just wanted to share as well, and then we'll take public comment. How best should we go forward?
Yeah, we can go ahead with board introductions, and then we'll have our guests introduce themselves.
Okay, groovy. So I will go ahead and start with, let's see, Rick Trelevin, you are up on my Brady Bunch box.
Okay, my name is Rick Trelevin. I'm the CEO of Best Care Treatment Services here in Central Oregon.
Excellent. Linda Johnson.
Linda Johnson, Community Rep for the Health Council.
How about Commissioner Adair?
Patty Adair, Deschutes County Commissioner. Good afternoon.
Hi, great to see you. How about Dr. Sharma?
Hi, Divya Sharma, Central Oregon IPA and an internist at Lapine Community Health Center.
Wonderful. And how about Dr. Allen?
Good afternoon, Gary Allen, Vice President of Clinical Services at Vantage Dental.
Excellent. How about Justin? And then we'll go to Brad.
Justin Civil, I'm the Chief Operating Officer of Summit Health.
Hey there, Brad Porterfield, Executive Director of Latino Community Association, Consumer Rep, CAC Chair.
Excellent. And how about Paul? Hi, Paul Andrews.
Hey there, Paul Andrews, Superintendent, High Desert Education Service District.
Okay, and as I've been introducing, and you've been introducing yourselves, all of the boxes are moving around. So I think that's board members. I've missed board members. Okay, I'm not seeing in my box here. Go ahead and how about board members that I have not called on? I think we're good. Okay, very good. So let's go with introductions. Donna, do you want to kick us off?
You bet. Good afternoon, everybody. Happy New Year. Donna Mills, Executive Director of Central Oregon Health Council, and my pronouns are she, her, and hers.
Groovy. How about Renee?
Hi, everyone. Renee Worth. Pronouns are she, her, and hers, and I'm a project manager with the Central Oregon Health Council.
Excellent. Camille.
Hi, I'm Camille Smith. I am the admin at the Central Oregon Health Council.
Keeping all things happening. Yes, thank you. Rebecca.
Hi, everyone. Rebecca Berry, she, her, hers, and I'm the Grants and Metrics Manager here at the Central Oregon Health Council.
Wonderful. How about Kelly?
Hi, everyone. Kelly Adams, pronouns she, her, hers. I am offering admin services to the Central Oregon Health Council, helping out with CAC and pain standards.
Excellent. Michaela.
Hello, everyone. Michaela Arsenault, project manager at the Central Oregon Health Council, and my pronouns are she, her, and hers.
Excellent. Trisha.
Hello, everyone. Trisha Wilder. My pronouns are she, her, and hers, and I'm the director for Central Oregon for the CCO.
Excellent. Justin.
Justin Sodio, Pacific Source. I'm the financial planning and analysis director. I guess first time I've had to say that. Thanks.
All right. That's great. Leslie.
Hi, Leslie Neugebauer, Senior Director of Medicaid Governance at Pacific Source.
Wonderful. Oh, Gwen. Hi. Sorry, my boxes are moving around.
No worries. No worries. Gwen Jones, she, her, hers, project manager. Happy New Year, everyone.
Yes. Excellent to see you. Sarah.
Hi, I'm Sarah Dobra. I'm with the Oregon Health Authority and standing in for Rebecca Donnell, who is on a well-deserved vacation. So thanks so much for letting me join you today.
Excellent. It looks really tropical behind you as well. So not sure where you're at, but it looks great.
Oh, great backgrounds.
Wendy.
Hi, everyone. I'm Wendy Jackson. I'm the Chief Operating Officer at Central Oregon Pediatric Associates.
Excellent. Kristen.
Hi, Kristen Tobias, she, her, hers, and I am the Community Health Coordinator for Pacific Source here in Central Oregon.
Excellent. Kat.
Hi, Kat Mastrangelo, she and hers, and I am the Executive Director at Volunteers in Medicine.
Wonderful. And I am seeing a phone number ending in 5256.
That would be me, Tammy Bainey, Dan Stevens with Pacific Source.
Hey, Trouble.
Hi, everyone. I will be on camera momentarily. See you
Okay, we
soon.
can't wait to see you. And then how about 8325?
That's me. This is Erin Fair-Taylor, Vice President of Medicaid Programs at Pacific Source.
Excellent. Glad you could join us. Okay. Have I missed anyone? All right. So shall we go forward? I just have a few comments and then we'll take public comment. Donna, does that work for you? Okay, groovy. So thank you for offering me a wee bit of grace as I get my groove on, as I mentioned. And I really just wanted to start by sharing appreciation for being on this journey with all of you. And wanted to take a moment to just reconcile the importance, I think, of, and sometimes maybe we come together on a monthly basis and don't really maybe recognize the lift that we've been given and the importance of the work that we do on a monthly basis and every day, really. And so I really want to help us to embrace the fact that we are creating a table where we wear one hat. And it's important for us to remember that as we come together, that we challenge ourselves in remembering that the Central Oregon Health Council is comprised of all of us for a really good reason. And that is because we are the individuals and the organizations and the community that has stepped into the space to say, we're going to try to make this different. We're going to try to break down what had been here for a system that has been decades and generations built to not get the outcomes that we are hoping to achieve. And so as we come around this table, it's important that we lead from a position, not from our organizations, but one in which we are coming together as the community, as the region of Central Oregon to try to affect this change. And as we come together, it's really important that we remember that this is not going to be easy, and we need to be intentional and courageous and really engaged in order to be able to dismantle what it is that we've all operated under for so many years. And so I really also want to make sure that everyone knows that we've come a really long way. It may not feel like it, but when we think back just 10 years, and it goes by so quickly, we were embarking on something that people just figured could not be done. And the system that we have today in the state of Oregon is modeled after our work. And so that community table, that voice for those who have not had a voice in the entirety of the system of medical care, now have a voice. And it's incumbent upon us to elevate that and to make sure that we really take a moment to celebrate the things that we've been able to achieve. And we've created a model that has reinvested millions of dollars back into the community. For those of you that have been in this work, I know we talked about going upstream all the time. Why are people falling into the river? Why are, we're looking for the ways in which we could actually achieve healthier outcomes. And we've been able to step into that space and be able to reinvest a lot of money that would have not been reinvested and try to break those silos and really reinvest in a different way. We've been able to address this in a way of thinking about our mission as one of not just medical payment reform, which was really where we were for many of the initiatives of trying to change the system, we've stepped into the space of really looking at the community health and what does that mean to have health and wellness for a community outside of just what does it mean to get a better return on our medical investments. And so I also want to recognize that I know that we are not where we want to be. And that's okay, because if it were simple and easy, it would have happened decades ago. And so that tension that we feel is a good thing, because that tension is going to push us through in being able to affect that change. And whether that's tension in the community, whether that's tension among partners, whether that's tension among us, that is a space that I want us to not shy from, but that's the space, in my opinion, where we are truly going to push forward and affect change. And so as we embark on this new year, I ask that we lean into that tension together, and that we are wearing our hat of the Central Oregon Health Council, and that we remember that we've been entrusted with a vision of creating a healthier Central Oregon together. And if there's a team that I know can continue to do that and is really going to remain committed, it's this team. And so I just wanted to start with saying thank you for the opportunity to continue to be a part of this group. I'm excited to be your tour guide on the journey for this year. And so I am excited about what's in front of us. I'm not going to shy from the hard conversations, and I hope you don't either. But I really want to make sure that as we come together around this table, we're wearing a hat that is one that's collectively our community. And with that, I'm going to go ahead and take public comment. So do we have anything that the members of the public or anyone really wants to share with the group? Not all at once, though. It sounds like folks are.
The clamoring is deafening.
Yes. Okay, so let's go forward with our first action item, which is the consent agenda. Do we have any changes or edits to the consent agenda? If not, I welcome a motion. Again, not all at once, though. I know it's.
So move consent agenda, Commissioner.
Thank you so much, Commissioner.
I'll second.
All right, Rick, thank you. Any further discussion? And how about we do anyone opposed versus everyone in favor? Anyone opposed? All right, so motion passes. Let's move forward with Brad with our patient story, the reason that we are here.
All right, thanks, Tammy. Happy New Year, everybody. Let's see here. So the patient story, if I'm on track here, happens to be related to chiropractic services, and the feedback from a provider that Pacific Source has been, our CCO has been saying that, and I guess OHA, if I attribute things wrongly, forgive me, has been saying for about 3 years that chiropractic services will be covered by Medicaid, and yet providers have not been reimbursed. And as recently as the last year, apparently it's on the books that chiropractic care will be covered, and yet providers, at least one provider that reported this, is still not being reimbursed. So that just came forward, and more broadly, for me as a CAC member and a board member, preventive care is really important in my mind in our overall health system, because it can save costs down the road if you address things early enough. And chiropractic care is one of those things where if you've got your skeletal structure where it's supposed to be, that you're less likely to have other symptoms arise and other illnesses and pain. So it's just one of those things, that came forward, and it's become an emerging issue with the advisory council, and we're moving it through our emerging issue process that we developed this year, and welcome input and feedback.
Excellent. So thank you for bringing that forward, Brad. Is that something with the emerging issues framework and process that you need the board to support you on, or is there, what is the ask of the board for today?
Anybody who has an interest, whose ears perked up, I'm sure Pacific Source, your ears perked up. But anybody else, so we're already awaiting feedback from Pacific Source and OHA, Oregon Health Authority. So that is to be determined, to be received. And if anybody else on the board has anything to say about that, please either speak up now, reach out to me, reach out to the CAC. And I do have more details. I just don't feel like this is the right space to read all the details in. So I do have something in writing that I'm happy to send. I think it's already gone to Pacific Source. I'm happy to send to anybody.
Excellent. And it looks like Sarah might have some comments that she'd like to add. I don't want to put you on the spot, but Sarah, if you'd like to, go right ahead.
Oh, thanks so much. Rebecca had flagged for me that this was a question that came up. So I did try to at least make sure I knew a little bit. And again, I can't necessarily speak for these specific rules at OHA, but I think the helpful piece for us to understand is chiropractic services are a covered benefit for any OHP member when that service is for a treatment that is on our HERC above the line guidelines. So the Oregon Health Plan covers services that are defined by our Health Evidence Review Committee, and they're called above the line items. And if there is a condition we cover for the Oregon Health Plan where chiropractic care is a treatment that would have a therapeutic benefit, that is when chiropractic care should be covered. And then as we think about member rights and appeals, I would hope, particularly for this member and any Pacific Source member, that they are receiving a notice of adverse benefits determination if that service isn't covered, so they can appeal, and that determination could really be seen if and looked at from that perspective. And so that is a hard one where it's not a clear chiropractic services is covered for this condition. It's really a secondary. And I'm happy, if it's helpful, just to pop in the actual HERC notes on that or send them to you, Tammy, if you want to include that. And again, I'm not the HERC expert, but I think that's all public documents that might be helpful in this conversation.
You bet. That would be great. If you want to put it in the chat or send it to us, and Donna can send it out, or whatever works best for you would be great. We'd be happy to disseminate that. Thank you for stepping in on that too.
Of course. And I definitely think about it from a member's perspective. And I just try to simplify a really complex topic, and I probably still confuse myself sometimes. So I think about, as a member is trying to access a care and service that they know has worked for them or has helped them, they may not be asking, and certainly aren't asking their provider, well, are you billing this for it above the line or not? And I think that's where we can think about, on the OHA operations side or supporting all of you, how do we make complex policies as set forth by the Oregon Health Authority accessible for members in situations like this where there's not one clear answer.
And just thank you, Sarah. One other thing that I would just throw out there is so it raises a lot of questions, and one is, and I have a bazillion questions because this is not my field, but I am very interested, curious, read up on it and so forth. And one of those is, is our health system analyzing the impact of preventive care? Is there any analysis? Is there any, analysis and consideration for how, things that fall into preventive care? A dental checkup, right? I think that's covered. Is an annual dental cleaning or checkup covered by Medicaid? If it is, somebody can
yes,
answer that.
I'll comment on that. Yes, it is. And in fact, there are maybe more frequent preventive encounters that are covered depending upon the risk factors. So generally speaking, yes, annual is covered, and in some cases even more frequent.
Thanks, Gary. Yes, it's a good example, right? An annual checkup or an annual cleaning with your teeth, that's preventive. And so, there's other preventive care that if we invest in it, we can lower costs, which I think we're failing miserably at. lowering the cost. If I'm not mistaken, I see insurance rates at least continuing to go up. I assume that's a reflection of medical costs going up, continuing to go up. So I just want to put it out there on the table and ask the question: is it being analyzed? And is there any movement or effort to focus more investment on preventive care?
So go ahead, Gary. Sorry.
Yeah, I just want to comment very briefly. I just completed my appointment to the Health Evidence Review Commission as the dental representative. So I was able to witness firsthand a very involved process of reviewing coverage. And prevention is very important in making those decisions, but also whether or not there is evidence to support. And I'm not making a comment about any one particular type of procedure or preventive encounters, but it goes through a very involved process. And I think that overall, among consumers and members on OHP and the public in general, I think that there is a bit of a lack of understanding of the role of the Health Evidence Review Commission in reviewing coverage and benefits and where they might fit on the prioritized list. It might be something, I don't know if there's a primer, that's available out there for people that they could review and see the process that's gone through to determine what's above the line and what's below the line, what's covered, what's not. But I think from my perspective of having witnessed, it's a very impressive process, and a lot of thought goes into it, and a lot of public testimony, as a matter of fact.
Thank you for that. So I think this would be a good one for us to have a follow-up on, Donna. If we, so Brad, when you get information back from Pacific Source, it sounds like there's more to this. And in terms of what would be covered benefits and the general statement of how that happens and how we engage on that, we could look at that being an agenda item for information. But really want to make sure that we, for this particular topic, that any information that you learn, that we get back to the board just so that we're informed in how it went, where it landed, and if there's anything that we need to do after that. Does that work? Okay, groovy. Wonderful. Okay, so it sounds like we should have had our meeting in Hawaii with Megan, but I was unaware that we needed to book our flights and all of that. With Omicron, it probably wouldn't have been wise, but and she may not have wanted us to join her, I don't know. But we have a couple other members from finance. I believe that Megan was going to try to join. Donna, where are we in terms? Should I maybe go to Pacific Source on an update? We have the next item for the performance metrics too.
Yeah, we could go ahead and pop over to Tricia for the performance metrics while we wait for Megan. She insisted on running up to her room, so.
Oh my goodness. Okay, well, that's dedication. Tricia, is it all right if we move you forward?
Yes, I'd be happy to do that. I'd also be happy to go to Hawaii. I'm a little cold right now and drinking some tea, and that would be okay. I just want to say thank you so much for your opening comments, Tammy, for this meeting, and thank everybody in this room for all the hard community work that is being done right now and always. We're going to talk about some performance metrics. And I just want to set the stage a little bit, Camille, before we jump to that slide. So just a moment, because once we jump to the slide, I'll lose everybody for just a minute. So we put together a group as a team of CCO directors, and Leslie as well as part of that team. And we talked to our internal subject matter experts to help craft some metrics going forward. And I think this is, in case you also didn't know, that these are metrics that are presented at all 4 of Pacific Source CCOs. So this is not unique to our region. And I think when we really funnel our organization into these 8 metrics that I'll show you in just a few minutes, I think it allows for a lot of opportunity to do a little deeper dive in those spaces. So the reason we're doing this work is that the dashboard provides the board with visibility into key areas of the CCO's work in support of the JMA that stipulates the Central Oregon Health Council's responsibility of collaborating with PCS to, and this is the key word, monitor the performance of the CCO. So that is directly spoken to in the JMA at 3.1.11. I didn't actually write the page number down, but it's very, very early in the contract, maybe page 2 or 3. And what that speaks, what that exact statement in the contract is, and I'll read it: establish and monitor performance metrics for the CCO and evaluate Pacific Source Community Solutions in its role as a CCO. So that is part of your role in this space, again, before we dive into what the metrics are. Similar to last year, we used 4 categories to do this work. We added some objective statements, and this will make more sense in just a moment, for each category. And more importantly, we pared down this work. So I don't know if you remember the giant spreadsheet. It had 19 metrics. Now I want to tell you that work is not going to stop just because it doesn't funnel into this forum. There will be some opportunity for some of that work to go into other committees, and then also some of that work was removed because it was more process oriented than it was performance oriented. So keep that in mind. But we really are hopeful that this is much easier to both digest and provide feedback to as we move forward. Let me see what I missed. We hope that the topics are of interest to the board. And we know that they're key priorities for the CCO. And I think the only last thing is that we will turn this, and Camille, go ahead and put up the document. We will turn this into a sort of the way you saw it before, which was such an easy way to look at a glance with the stoplight tracking, green on track, yellow, a little bit of caution, red, we're working on some plans, some action plans to get back on target. So we will take this and put it back in that format again. It just won't be as large of a document. Having said all of that, before I dive into each one of these 4 categories, does anyone have any questions there? That looks like a no. Okay, let's jump in. We're going to start on the quality and member experience. And the CCO, I'll go ahead and I'm just going to read these. There isn't a lot of opportunity outside of talking about this in a slide deck way. So the CCO improves care, makes quality accessible, and eliminates health disparities for our members. The first metric we want to measure there, and this is probably not going to be a surprise, but it is to meet at least 11 of the 14 quality incentive targets. Now, if you're wondering why 11, because that sounds like a random number, it is because that means 100% payout, which is something we have achieved every year as a CCO. Donna, and correct me if I'm wrong, except for in 2018. Does that sound like a reasonable place to start? Any comments on that metric? Okay, let's jump forward. The second metric is one of our 2 process metrics. So we tried really hard to have these all be performance-based, but it's challenging in that space to make that happen. So the second one is a gap analysis pertaining to the availability of mental health services will be completed and used to strategize solutions for identified access issues. Now you're going to see that there's a little number 2 there. And what I want to reference there is that work specifically will happen in alignment with the state's performance improvement project. So you go, great, what does that mean? I'm going to go ahead and read to you from the OHA website what that means as well, to hopefully, it's still a little elusive, but might shine a little light into that space. So what the performance improvement project on mental health access monitoring means is this involves CCOs across Oregon working in their communities to ensure access to mental health services for OHP members ages 2 and above. To support the project, a measure with multiple stratifications was developed to ensure to ensure equality in the delivery system and aid in reaching OHA's 10-year goal to eliminate health disparities. Again, the really high level picture of why we do this work. So it is a process metric, but does anyone have any questions there before we proceed to the CCO 2.0 requirements? Great, let's jump into those then. Oh, I'm sorry.
Tricia, sorry. I just wanted to back up. I was a little slow in thinking that I had seen this information somewhere, but I'm not finding it. Back to the 11 of 14 quality incentive measure targets that were met. What are the 3 that were not met?
No, we are proposing that we will meet at least 11 of the 14 metrics for 2022. And that gets us to 100% payout. So we hope we meet all 14. We're not pre-selecting any that we aren't going to meet.
Gotcha, thanks. I thought I was reading this as a report and not a plan. Thanks.
Yeah, absolutely. Anyone else before we switch quadrants?
Tricia, this is Rick Trelevin, and for the OHA statewide process improvement, whatever with mental health services, has the state published that plan, or is that just sort of an aspirational thing that they're telling you at this point?
Leslie, can you jump in this space?
Yeah, I haven't seen the specifications, but I was told by the folks that do the performance improvement planning in our organization that the first kind of draft report for our plan for a gap analysis isn't due until mid-year. So we'll know much more, I think, in Q2 of this year.
Okay, great. I just wanted to make sure there wasn't something I should be on top of.
The state usually gives us 90 days in advance of any templates before a deadline. So we'll know again, Q2 probably.
Thank you, Rick and Leslie, for jumping in. Just a reminder to y'all, I'm in my 6th month in this role. So while I am gleaning understanding in the vast amount of work that we all do, that deeper dive answers may come from Leslie, who is in this role for over 6 years. So thank you again.
You're doing a great job. And it's a little difficult for me to see the raised hands. I do see that Justin has his up, but for others, thank you for using the raised hand. But if we don't call on you, go ahead and just pipe in so we don't miss your comments or questions.
Sure, mine's just real simple. It's the goal is 100% payout or to meet the targets on the metrics.
100% payout.
So if the state changes the targets again, we'll consider that a success, even if we don't meet the original targets, as long as we get paid out.
I would say yes to that. Leslie, I see you on mute. Do you have anything to add?
There's 2 metrics. We just haven't gotten there yet. There's the one on the financial stability piece around 100% payout, and then this is around targets. So I think it's a little flip-flopped there. So for quality experience, yes, we'll meet the targets. If the state changes those, the metric will stay the same. We need to continue to meet those targets. The payout is
so
on the
then
right.
that is different. Then the goal is, if we say 70% of people should get a test or something, whatever it is, whatever the metric, even if the state relaxes the standard, if we don't make the 70%, then we didn't deliver the care that we wanted to, so we didn't make it then. Is that what you're saying?
Yeah.
Thank you. Appreciate it.
Sure.
Hey, can I just jump in there, Justin? Because it sounded like Leslie was saying one thing and you were saying another. You brought up a really good example, Justin. So let's say it's 70% of people in a certain measure require a preventive test to hit the measure. Historically, if the state changed it midstream, it was in recognition that, obviously most recently because of COVID is the best example, with either difficulty in the provider environment or in the data environment or such in response to the pandemic environment might have lowered some of the measures. Leslie, I think to what Justin's saying, if they lowered it from 70% to say 60%, and we hit the new threshold, but not the original threshold, Justin's question is, would that measure be one of the 11 that counts? And I think the answer is yes, not no.
Correct.
Okay.
Yes,
I just
sorry
wanted
if
to
I
make
miscommunicated. Currently the rebase targets are at for 2022 performance is they're set at 50%. So they are lower than they were previously pre-COVID. This was the OHA's 2-year plan.
Right.
So we're in the 2nd year of that.
And
Understood.
Justin, oh, go ahead, Justin.
No, understood. Thank you. That's the quality metric is considered accomplished when the payment is made. If the target moves and fewer people get the service, as long as we meet the target that the state set, then we were successful. I understand.
Right. If they move
Thank
the
you.
bar, it's a good question though. And obviously the goal would be to hit the original metric. We would accept it if we hit some sort of revised metric, but maybe not with as much pride as we would have had. It's a good question.
I really appreciate that level of question, Justin. It's clear the level of understanding you have in this work. And just also to clarify, we did meet at 100% of the quality incentive measure targets. That doesn't mean it's 100% payout in 2021 due to the emergency outcome tracking measure or the COVID measure. So there are some further statements to that in the board packet in the director's report.
And I just like it when Leslie's wrong because she's only wrong once a year. So
Well, gosh, it's a little early for my 1 time a year. I might need to.
That's your
Let's
point.
define wrong.
Thanks,
I was
Tammy.
going to say,
God,
check
it
that
was so
box.
it's so much easier when Rick was chair. You could do stuff like that.
Hey,
he did all the
we're not even a
wrapping.
half hour in yet.
And I always knew that Leslie was never wrong. And so, so I would say that if you called her out, then you're wrong on that one.
Okay, Leslie, that's my one time. Move on, please. Thank you.
Okay, yeah, here we go again. Let's jump to the CCO 2.0 requirement quadrant, shall we? This quadrant talks about how the CCO will meet all CCO 2.0 contract requirements, right? It's our contract with OHA. In that space, the first metric talks about at least 50% of the provider contracts are in a value-based payment arrangement. And for the people who work in this space, it's the LAN framework category of 2C or higher. If you don't work in that space, that's as much as you're going to get from me. But I will tell you that Central Oregon is a leader in this work. We have been working in value-based payments for a long time. And we are potentially even above this 50% threshold at the moment. That will change for going forward. So we do have work ahead of us. But again, this entire CCO performance metrics are for all 4 CCOs, and not all the CCOs are exactly where we are in this space. So does anyone have any questions there before we move on to metric 2 and CCO requirements? I see Megan.
Hello. Hey, I'm curious in this bucket how it interrelates with Senate Bill 889 and the compact with the insurance companies being a little more aggressive with the achievement of the LAN framework. And do we need to adjust that or do we need to monitor that? I just would love some insight there.
I can just start and maybe Deanna, if you have anything to add. That's a part of our strategic plan and has been for the last, well, this year and last year. So it's certainly work is being done pretty regularly internally for all lines of business and getting provider contracts up to this level in all of our lines of business. So that we certainly have a plan around that and a roadmap. It's very aligned, as I'm sure you know, with the CCO requirements purposefully. So I think that the percentages year over year are similar, if not exactly the same. There are some changes in the categories over time. So I think in 2023, we're going to be looking at 3B or higher. I would just ask folks to Google that exact land framework, and you can find that really easily. But we're looking, we have a roadmap. We're looking way ahead, having conversations with providers currently. So it's very top of mind.
And Leslie, I'm also thinking, is there any role of oversight of the Health Council just specific to the Medicaid line of business based on those accountabilities? And you don't have to answer now, because I know that's still kind of a strategic, you know, where you're in a strategic place, but just curious from a governance perspective if there's a role.
Yeah, it's a great question. We'll take it back to our team.
Mm-hmm. Thank you. And thank you for joining us from Hawaii, Megan.
Yes.
I hope it's easy on your knee. The next metric we're going to discuss is something that we'll do in partnership with Oregon Healthcare's Interpreter Association, and that is to both train and certify up to 60 culturally and linguistically responsive healthcare interpreters across the Pacific Source Community Solutions contracted medical interpreter vendors. So we've talked some about class standards and work here in this space. So we're really taking this one to the SMART goal and feel really confident we can be very close to 60 on this mark.
Hey, Tricia, this is Brad. Is this just for the Central Oregon region, or because I know Pacific Source covers multiple? It's just this CCO, right?
No, this would be for the healthcare interpreter associations that work across all 4 CCOs.
Okay, so I guess my concern would be that 59 interpreters or even 60 could be in areas other than Central Oregon, and then here in our CCO we've failed. So I would hope there's some, I mean, I'm sure you're thinking of this, but that's my concern.
We did, and we talked about this, if you can imagine, specifically in the Gorge. And you know, what do those total numbers look like across the CCOs? I can certainly bring this back to our team. I think another option would be to just continue to keep this board updated with what the Central Oregon specific numbers are, since that is what this board is responsible for. And I'd be happy, you know, we will report. This is just an identification of the data and what we're going to continue to talk about in quarterly formats, if you will. So, you know, it'd be very easy then to break down how we're performing within this region, and then also showcase what that looks like overall. If that would feel like a measure, that would be.
Yeah, thank you.
Tricia?
Yes.
This is Dan, and at the risk of being wrong twice, it's my understanding that the Oregon Healthcare Interpreter Association is, if somebody gets trained and certified, they could become a resource across the state as opposed to dedicated to one region, right? So I think while Brad's question is really important, it might be another dynamic that a trained and certified interpreter is somebody who isn't always deployed in specific to one region or another. Is that correct or not correct?
I do believe that is correct. Sorry to jump in, Tricia. And I was just thinking about this measure is, I mean, we have a pretty robust plan for 2022 and beyond, not just with our interpreter vendors, which is what this measure is speaking to, but also with individuals that work in medical clinics now or will work in provider offices, for example. The big issue here, so we have a training plan. We have something, you know, some big training plans ahead in all regions and specifically in Central Oregon. The issue here is the certification piece. That's our history with offering healthcare interpretation trainings has been, we get a lot of people at the trainings and there's a lot of interest. And then the number of people that actually get certified is much lower. It's also a really difficult, it's not a simple task. It's a difficult test. There's a lot of hoops to jump through. There's a lot of documentation. So there are some there are some kind of hoops to jump through there to get to the certification level, which is why that part is in italics, because that's the bit of the uphill battle piece that's going to be a challenge to continue to support people through certification.
I can add one more thing in that space, is that we've provided incentives for people to not just do the training, but also continue on if that was omitted there. So, but I will clarify what that is if we're comfortable with that generally being one of the metrics, and then speak to that more specifically and ensure that regardless of where those interpreters are trained, that they're able to work across the CCO areas. If you find that acceptable, we'll continue forward. Great. Let's jump to financial stability then. The CCO ends the year with a positive financial position, trying to really keep this in a simple form. So the first metric just follows to achieve a positive net income. Now, this is a CCO that, as you recall, our budget also was approved with a 2% recapture as built-in part of it. So we didn't address that as part of this first metric. So I just want to clarify that this is just to achieve a net income. And again, this is something that would cross over all CCOs a little easier. It doesn't go in place of course, the work our finance committee does. Okay, we'll jump to the next one, which is really also, this work is so interlinked, but it's to achieve 100% payout on the quality incentive measures. And really, when we do that, the financial stability is much higher. Again, our budget is based on a 70% payout. So just keep in mind that there are some nuances between committees and metrics. But again, we wouldn't want to have a goal be 70%. The goal is 100% payout. And just because a budget was based on that, again, over the time the Central Oregon Health Council has been in existence, only one time have we not achieved 100% payout. Rock stars. Okay, does anyone else have anything on this part of this quadrant before we move to the last quadrant in operations? Great. The CCO monitors and evaluates operations to ensure optimal performance. So what that looks like in the first metric is to closely monitor annual external quality review activities and address any health services, advisory groups, OHA inquiries in a timely manner. Any corrective action, we will do it quickly. It's one of the things we're actually very, very good at, amongst many others. Let's jump to the last metric then. And this is to meet our response time of 30 days or less for 100% of appeals and grievances received. Anyone have anything to add on operations before I ask one more time for any questions for Dan, Leslie, or I on the overall performance metrics?
Hey, Tricia, this is Brad. That last metric, it just seems to me that the meet response time of 30 days or less, that's not nearly as important as an actual follow through resolution type of metric. I mean, responding is great, but what if every grievance is just nothing good is coming of it? So I don't know what you can do with that, but that's my input.
There's a couple of ways I think I could speak to that, but Leslie, I did see you pop that unmute there for a moment. The goal is to resolve this in a way that I would say is beneficial to the member. So you're right, it isn't always achieved in that way. this would allow for closure in those spaces of 30 days so that, have you ever expressed a concern and then just never had an outcome attached to it, or it's delayed considerably longer than 30 days. So Dan or Leslie, do you have anything you could add in this space that could be helpful here?
I was trying to look up the contract language quickly, but I couldn't get to it quick enough. We'll get some clarification on that, Brad.
Brad, I would say some of the lingo in here is kind of, inside insurance baseball. In other words, resolved, sort of response time versus resolve to the member's satisfactory outcome. Sometimes and we could illuminate this. We could bring back sort of a, take the lid off of the appeals and grievance function and talk about some of the things that happen in there, the kinds of appeals that come in, the kinds of outcomes, the decision-making process, which is really important and also very member focused, the levels of review. So if that's of interest for the board, that could be done. It's a really interesting function, and they have some tough decisions that they have to make. What they're balancing often is something that the member might want, but something that isn't covered. And so it becomes sort of a balance between compliance or stewardship of dollars, especially if it is an evidence-based care, which is one of our stewardship requirements to the OHA and I guess to Oregon taxpayers. So there's a lot of nuance in there that probably doesn't allow this to cleanly say, resolve to the member's satisfaction, even though I understand that would always be the goal, at least the philosophically aligned goal.
Yeah, thanks, Dan. It just feels if all you're measuring is that you're getting back to people, that seems pretty superficial, like pretty unimportant. I mean, it's obviously it's important, but it doesn't mean anything beneficial really took place. So I don't know. It just seems like there could be a richer metric there.
I think sorry, Brad. I think resolution might be the word we're looking for here. This is not an initial contact point. We have much shorter metrics for that. So this isn't we will reach out and talk to you in the first 30 days. This is we will resolve this in 30 days so that the member would understand that this wasn't a billable service or they've been routed to a different location. Potentially this could be a flex service opportunity. So it would be resolution. So again, it's that like wondering, is somebody taking my problem? I talked to somebody this week. Oh, they're back to me the next week. And now it's not the answer maybe I was hoping for, but there's a resolution to it. So the outcome.
Yes, I think it's, I mean, maybe just reword it because it definitely doesn't read that way to me.
Yeah, I can see that.
Mm-hmm. I think that was our intent. Don't you think that, Leslie, as well?
I think so. I'm still trying to find the language, but yes, I think so.
It may be good to take this one back, and I very much appreciate this conversation because that's why it's coming before the board for this sort of engagement. And so are there other pieces to this that we maybe want to have reviewed if we're taking the time to send this back? We can bring it back for the February meeting so we don't have to have a whole lot of time lapse. It sounds like maybe some wordsmithing is on the horizon. Dan, is that, or Tricia, does that work for the team?
It makes sense to me that we come back and bring some clarification to that, kind of in the spirit of what Brad is suggesting. I like that a lot. I was actually going to go to the one above it. I didn't see these before they came in. A board member question might be, how do you define timely manner? So how do we know we're actually meeting this metric unless we've defined timely manner? So Leslie and Tricia, we might want to come back and be more specific about that so that we know what we're measuring.
Mm-hmm. Does anyone else have anything? And then I would love to summarize the 3 things I think we're going to continue to work on.
I
Great.
have finally confirmed that it is resolved in 30 days or less. Good Lord. I'll never forget. At the timely manner piece, part of that, Dan, is that we have, as you know, the annual audit, but then HSAG sometimes comes to us with a handful of things throughout the year. So the timeline is kind of ever changing. I mean, we've never missed a deadline, obviously, but
that makes sense, Leslie, and I didn't
Yeah.
mean to cut you off. What we
Yeah.
might do then is just to add for clarity that something we can figure out better words, but that we're responding timely so as not to be out of compliance with OHA, right? So the goal here is to be in compliance with these inquiries and or any sort of corrective action, to be in full compliance. So maybe that's the finer point we could put on it.
Okay, we will internally work on some language to improve upon timely manner. We will rewrite the metric around resolution in that same operational space. And then I have in my notes to also go back and look and help ensure that the second metric in the 2.0 requirements as it regards to the interpreters is also across CCO. So is there anything I'm missing? Thank you all so much. You are the first health council that this was presented to. So thank you for helping the other health councils move forward as we do all the time. And have a wonderful rest of your day.
Excellent presentation, and thank you for the openness of hearing that feedback as well. And so Donna, let's tee this up if you don't mind for next month, and we'll make sure that we get it back before the board. Okay, now to Megan.
Hello from Hawaii. It's nice to see everybody. I'm not going to put my video on because I don't want you to see the beautiful background here. So we are back to the group with our CCO budget. And I think you remember last meeting that the Finance Committee had recommended some edits to the proposed budget back to the Pacific Source team so that the budget would not have a recapture in that. And the team did go back and they worked on the budget and they were able to accomplish that, along with a couple of scenarios that I think are really interesting for the group to see. From a process perspective, this budget has been approved by the Pacific Source Board. We had hoped to do this at the last meeting, but I think there was really great input at the Finance Committee. And so we're just a little out of sync like with our normal process, but I think that there's a really great budget coming forward to the group. The Finance Committee did review it, really great discussion, and they are recommending approval to the full board. And so I am going to turn it over to, is Justin on? There he is. To Justin.
Yeah, so for the group, I was just going to give some very high level updates and then open it up for questions on the budget. But as Megan mentioned, overall, there's a small surplus reported on the 2022 budget. The margin is below 2%, but because we do some adjustment on the subcapitated revenue, it does result in a JMA surplus. So some of the kind of high level assumptions that we went into on the budget, putting this together, our membership. So looking out into 2022, also knowing that redetermination currently is not happening, we got some information that showed that the full impact of redetermination wouldn't be seen in membership until about 16 months after they declare the state of emergency to be over, and that still hasn't happened. So one of the main assumptions in our budget was that there's no impact of redetermination in that our membership, so no decrease there, some slight increase based on additional members coming on. Another one of the things I did want to highlight, there's a new program that is Cover All People. It's a program that begins on July 1st. And this program is for people that are medically underserved. So it includes undocumented adults, DACA recipients, and then legal permanent residents and young adults who are aging out of Cover All Kids. So that's just an additional program that they're starting. And then QIM performance. So our budget is quite conservative. We have just an assumption of 70% performance, which is, as I believe Trisha mentioned earlier, one of the lowest ever that we've achieved. We've always achieved higher usually, especially in the more recent years, but we do just like to be conservative to kind of build up to that performance. And then kind of the last highlight I wanted to provide was the aggregate claims trend that was applied to the claim section was about a 6% increase based on kind of the utilization and trends we've seen in the population, as well as just based on information we had on our existing contracts at the time. So that is kind of the high level summary I had. Any questions or added details I can provide?
Justin, do you have that visual that we had at the finance committee meeting with the graph?
Sure, let me grab that.
I think this is helpful for the board to see the budget, but then also some potential scenarios around performance that could be achieved based on a couple different opportunities or additional assumptions.
And for the board, we will be moving toward either a motion of support or any adjustments that you might bring forward. So I want to make sure that you see this in that light.
Okay, so in front of you, we have kind of 4 different bullet points. The first point that says draft budget was the budget version that we originally brought to the finance committee. The second bullet point being the version that we are that finance committee approved and we are seeking approval for here. And then there's 2 scenarios that we kind of modeled out for the finance committee to see. The first is a revised QIM performance up to 100%, meeting all the metrics. And as Trisha mentioned, that just requires meeting 11 of the 14 metrics, not all 14. So that's what this scenario would represent. And then a scenario 2 here would just be some kind of claims savings achieved either through kind of lower utilization, additional contracting savings, or just additional management of the population and their conditions. So as you can see, the current version is kind of just about spot on with and this is looking at the JMA margin. So it's kind of determining whether there'd be a surplus or a recapture from the Health Council's standpoint. So as you can see, current budget is about spot on with that JMA percentage, a slight surplus. And then the other 2 scenarios really just increase the margin, meaning anything between the orange and blue dots would be savings going to the Health Council. Megan, was there more you wanted me to go into on this?
No, I think that's good unless there's other detail the board would want, or I'm curious if there are questions with seeing this visual too. Or maybe it's just so good, there are no questions.
Sounds like we're leaning in that direction.
I'll take it.
I'm looking for furrowed brows. Some people are off camera. Paul has a smile. Okay, so if we don't have other questions or things that we want to talk about with this particular item, I would welcome a motion for accepting this recommendation as presented.
So moved.
Second.
Okay, thank you, Megan. Thank you, Paul. Any further discussion? Okay, hearing none. How about anyone opposed versus everyone in favor? Anyone opposed? Okay, motion carries. Megan, thank you so much for joining us from far away, and so grateful that you're having a moment that you can just relax and turn everything off. We're thinking about you. Please don't think about us. And great job, Justin. That was really well presented, and appreciate you both very much.
All right, thank you. And I won't be returning to Hawaii, but I will be dropping off so you guys can continue on. Thank you.
Okay, excellent. Enjoy the day. And thank you to the Finance Committee for your investment of time in bringing this forward. Okay, next item on the agenda is the strategic plan update. I'm going to turn it over to Rebecca Berry.
Thank you, Tammy. Okay, I have a few slides just to go over. This is just our brief update around the Health Council strategic plan. Give me a second there. Okay, I have everyone's faces. Okay, so the COHC staff have been hard at work continuously tracking, monitoring, and accomplishing various aspects of all active action plans within the COHC 5-year strategic plan. By now, this image is starting to become familiar. I just wanted to draw your attention once again to the 3 pillars in the upper left-hand side. These pillars are what drive the Health Council's work. So that's CCO governance, long-term systemic change, and the raw and the rip. And here you'll see the 3 pillars have 5 areas from the COHC strategic plan itself that will help to move us closer to our desired future state as an organization. These 5 areas are the things that guide our 5-year plan, and they are sustainable multi-sector integration, COHC as the health improvement convener, strong values and leadership, exceptional CCO performance, and last but not least, vibrant, healthy communities. So within the strategic plan, there are also 5 key directions that help move us toward our desired future state and closer to the 3 pillars we envision as an organization. So these 5 directions are creating aligned partnerships for innovation between payers, delivery systems, and patients, incenting better outcomes, engaging regulators for informed decision-making, investing in developing data infrastructure to support continuous performance improvement, demonstrating effective governance, and identifying and addressing inequities. Each of these areas have multiple action plans that are being tracked and updated quarterly to ensure movement toward our future state. So each of these have anywhere from 3 to 11 action plans surrounding them. So here is just a screenshot of how we are internally tracking all of this work. We have a very large and detailed document that continues to track this, and we come together on a quarterly basis to update this document. This Gantt chart here is our table of contents, and it's used to track the progress of every action plan. A Gantt chart is a bar chart that provides a visual view of project tasks scheduled over time. Just want to make sure everyone knows that word. So there are a total of 44 action plans currently in progress and at various stages. Each COHC staff person has roles in many of these action plans, and board members are engaged on an individual and tailored basis throughout many of those action plans. And just to note, we are on track with each active action plan for our strategic plan to date. Here you'll see an example of what each of the 44 action plans look like within that action plan tracker. So there are steps that need to be taken, who is responsible, by when we hope to accomplish those little tasks, and costs and resources involved. So each of these 44 action plans are updated every quarter. So as we discussed last fall, we are currently in the process of collecting information from each board member organization's alignment with the current regional health improvement plan. The intention of that survey is to assess alignment with board member organizations and the priority areas and future state measures within the regional health improvement plan. We are always stronger if we collectively aim to impact our region's health. We're still awaiting some results from a couple of organizations, and governance will review those combined results and share that information and any potential recommendations at the February board meeting. When we resurvey the board at a future date, the staff will engage a variety of sectors to ensure the aim and wording of the survey is clearly conveyed moving forward. This is a screenshot of the letter that each board member signed and is published within the Regional Health Improvement Plan. I know you've all seen this before. This letter states that the COHC board commitment, it commits to the following 4 aims in support of the Regional Health Improvement Plan. Pursuing the priorities, goals, and strategies described in the Health Improvement Plan, continuing to build systems of health that support these priorities and meet the needs of the region, aligning plans of our respective organizations within the RIP priorities, and facilitating cross-sectoral partnerships to achieve these priorities. While this letter was signed in 2019 in order to publish the 2020 to 2024 Regional Health Improvement Plan, all of the aims described in this letter are actually part of our COHC strategic plan that was created just a half a year later. And here are all the signatures assigned with that letter. So within the 5 areas of our strategic plan aims, the red boxes highlight where the RAW, Regional Health Assessment, and Regional Health Improvement Plan are mentioned as ways to move us toward our future state as an organization. And here, these actionable strategic directions, under demonstrating effective governance, one of those key areas is stewarding a really successful regional health improvement plan. So what's next? In February, all board members will receive a short, I'm going to say that one more time, a short survey asking for input on the Health Council strategic plan as it pertains to Central Oregon's current environment as we are now. And the reason for this is the strategic plan was launched at the start of this pandemic. A lot has happened in the past couple of years. So we're 2 years into this plan and we are well past due seeking input from each of you on it. At the March board meeting, we will also engage all board members in a facilitated conversation and polling activity to collect additional information around the strategic plan. The results from the survey and the March facilitated conversation will be compiled and shared at the May retreat, and discussions and any next steps will occur at that time. Do we have any questions?
Well, I know I'm looking forward to the short survey in February. I don't know about everyone else.
Yes, the Regional Health Improvement Plan survey was a little long. I think we've learned our lesson.
Not a worry. Great presentation. Any questions or comments for Rebecca?
Thank you, everyone.
Right. Great job. Okay, we will move to the next part of the agenda. Super excited to welcome Janice and Emily with us. Wonderful to see you both. And so I will just go ahead and turn the floor over to you.
Okay, thank you, Tammy. Hello, everyone. I'm Janice Garceau. Most of you, we've met each other in various walks. I'm the Director of Behavioral Health for Deschutes County Health Services, the local community mental health program. And I co-chair the COHC Operations Council with Emily Salmon. And I'm gonna give her some room here to introduce herself really quickly before we dive in.
Hi, everyone. Thanks for having us. I do know many of you as well from different arenas. I'm Emily Salmon, Population Health Director for St. Charles Health System. And as Janice said, we co-chair Ops Council and the QUIM Group.
And it's been an interesting 2-year gig, 2-year period to be co-chairing a group of people involved in healthcare and talking about meeting targets in the midst of a global crisis. So really briefly, I think we were asked to come and talk with you a little bit about just how this group operates to help keep the community on the path of success in terms of reaching the quality incentive metric targets. We in our group are aided by our CCO partner, and I really want to call out in particular Teresa, whose last name I am blanking on right now. McIntyre, who is just an incredible partner in terms of always having a strong sense of the data, sharing the data with us in a really organized, regular way, in an understandable way, breaking it down. And most importantly, to many of us in the group, connecting the data to what it actually means on the ground in real members' lives. So what does it mean when we're not meeting targets, for example, in childhood immunizations or diabetes monitoring or follow-up after ED visits. So there's been a really good partnership there in terms of connecting the data to the health impacts for real live humans in our community. So we use monthly data to look at where clinics are with respect to the targets. The QUIM work group in particular is attended, we hope, and we are always checking, by people who are intimately involved day to day in really attending to the kinds of data that helps clinics know in the moment how they're performing on some of the QUIMs. So often it's data analytics folks or population health folks, and on occasion with smaller organizations, it's people like me who has a footprint in lots of different parts of operations. The meetings are used to share information, but also to problem solve. So when we take a look at a particular metric and notice that the data is telling us we may be at risk of not meeting the mark, we spend some time with the people in the room problem solving the efforts that clinics are making to get there, which is often probably the more interesting and inspiring part of the conversation, is hearing clinic staff talk about some of the innovations that they've engaged in, or just grunt work, frankly, to encourage people to be paying attention to some of these important health outcomes and how we're measuring getting there. And then we've spent some time periodically throughout the year educating members of the group at the system impacts, both in terms of health outcomes, but also the fiscal impacts of meeting the targets and what sorts of dollars that brings into the region. Emily.
Thanks, Janice. I'll pause there in case anyone has any questions on what Janice has shared. Okay. I'm going to jump into and talk a little bit about how the Ops Council, so the two groups, Ops being a bit larger, higher level participants in their organizations, and then QUIM work group, like Janice said, having the folks that are really at the bedside or in the community doing the work. And in ops, we want to make sure that we are celebrating successes, which, as you can imagine, in the last 2 years has looked a little bit different than they had in years prior, as well as talking about areas where we fell short and how we might improve. And so in thinking about our success in both of those areas, we ask a lot of questions. What happened? Why do we think that happened? What does it mean? How are we defining success this year? And I think that what we heard in 2021 was an overwhelming desire to get our community vaccinated. And we can't lose sight of the QIMs, right? But we also knew that our entire health system would topple if we couldn't get people vaccinated. We're experiencing that now with vaccination and testing, right? And so we really had a lot of good conversations about where the QIMs intersect with that work. Because at the end of the day, they're all measures of how to have a healthy community. And so one of the ways that we can facilitate these conversations, and that is key to this work, is that those meetings are closed, allowing for medical groups, community groups to come together and to talk about really hard things in a very safe space. And so I want to, thank the council for the work that they do to foster that safe space for those teams. We'll talk a little bit about how we look for opportunities. First is data, quantitative and qualitative. So as Janice mentioned, Teresa does a fabulous job of working with the team at Pacific Source and bringing us data, both data that is routinely delivered to us in a timely fashion and in a reliable fashion and in the same format so that we're seeing it the same way every month, but also bringing us data that we ask for as we dig a little deeper on some of our questions. We want to be a group that's making data-driven decisions. And the qualitative portion of that data often comes through our meetings, right? Where groups are reporting, this is what we're hearing from patients, or this is what we're hearing in the community. And our goal is to try to bring those two things together and to understand where the opportunities may lie. And that's all in support of using our limited resources to their highest impact on the things that are most important now. And again, that theme of what's most important now has been different for the last 2 years than it was in years prior. I've participated with OPS and QIM work through the Health Council for many years now. And so it has been an evolution in the best way. So, I share that for what it's worth. Part of the ways that we look for and go after opportunities, both in the QIM work group and with the Ops Council, is, creating a format. And we're actually trying to talk about what should that format look like going forward in light of a changing landscape with COVID that probably isn't going to change anytime soon. I think the last couple of years we kept going, we'll get there and it'll be over and we'll go back to what we know. And I think that what we know now is this is it. So we're going to, we've been kind of rehashing what might that format look like. Do we want to take more of a kind of a project management rigor and bent to coordinating what we learn together? And it's a fine balance between having collective impact as a community through ops and not creating more work for clinics and community providers that are already overtaxed. And if you ask me, and I think Janice would support this, I'm going to turn it over to her, that is at the heart of the problem we're trying to solve right now in these two groups. How do we not add burden, but add coordination? So Janice, how'd I do? What'd I miss?
I don't think you missed anything. I think I would absolutely echo that that's been the challenge of the year. And I think the hardest thing about 2021 was that it was actually harder than 2020, which I know you can all relate to. And it was a bit of a surprise. So we're dealing with an enormous amount of community fatigue. The other thing that's a challenge is, this isn't necessarily scintillating work, and especially not in a Zoom. So just keeping members engaged and interested in problem solving in a Zoom environment around things like data really can be challenging. So Emily and I have talked about what are some things we can do to just bring a little bit more energy into the room. I think it was really helpful when we shared with people how close we were on certain key QIM targets, that if we met those targets would result in dollars coming into the community that were significant. I think that was a moment of increased energy. And now we're talking about really continuing to remember that this is called a work group, and that probably means we need to do a little bit of in-between work, like things as tedious and boring as have a project plan and have a way for people to see where they are during the interim between one meeting and the next, how they're performing, share some ideas, and do some problem solving so that we come back together. We're talking about what we've accomplished and not necessarily where we might be in trouble, which is much less fun to talk about. So we're always trying to think about how to keep this engaging, keep this motivating, and keep it tied to the underlying reason, which is people's welfare in the community, people's health. So, Divya, and then Linda.
I couldn't help but thinking when you were just saying kind of like the 2021 challenge was bigger than 2022. That's not surprising given the workforce shrinkage. And if you had been at our PEP meeting yesterday, heard it very loud and clear from the provider leaders of just how absolutely exhausted, and the priorities are very, very different because of just workforce short. I mean, literally the biggest priority right now is for them to figure out how to keep seeing patients when their MA staff is down to 20% of what it used to be. So I think the fatigue and the appetite to even discuss QIMs, like I know from a provider side, is just very, very low right now. And the morale is really low. So it's just an interesting dynamic, right? Because from the operation side, the group is close and at the same time, there's no letting up. I mean, yes, the targets are less and all of that stuff, but just it's still a lot of work that still is being expected to be done. Whereas, sometimes it feels like to the detriment of being just focused on patient care.
So Divya, what I hope, I absolutely 100% agree with every single thing you just said. And we are at 50% capacity in our mobile crisis staffing. We're at 50%, actually less today, in our new client appointment staff. Our residential treatment providers, I see Rick on the Zoom, are down. We have people out with COVID. I mean, we're exhausted. You're absolutely right. So the work that people like Emily and I were able to do because of our role both in the QIMS and on the metrics work group with the CCO is really talk about how to get the targets sized to the extent that OHA will allow us, how to get the targets set at a reasonable level and not be, adding insult to injury, frankly. And I think we did some good work around that. I mean, would we have preferred to not have to do it at all? Yep. But that just wasn't an option. So I do feel like at least our CCO partners were understanding of that and advocating for us with the OHA around keeping QIM targets somewhere in the range of what's attainable given the challenges we're facing with workforce. And the tragedy for behavioral health, and this may be true in the physical health lane, is we've had a historic investment in behavioral health in the state of Oregon, and those dollars literally, if we can't find staff, they won't make any difference in the community. So it's really breaking our hearts because we waited and waited and waited for that investment. We can't find people to fill important positions. Linda.
I really am valuing this conversation. And so I want to comment just a little bit on the piece we've just been talking about and then go to my original question.
Yeah.
Divya, what you described that health providers are facing with exhaustion, absolutely get it. And I think in addition to that, maybe not to the same degree, but to some degree, every individual on this call, every person in our community is really starting to become aware that there's no what we were before, that we're all somehow fundamentally changed by this somehow. And we don't really know, without grief that's focused on a person or a particular event, where to go with that and how to start organizing our lives in a positive way forward that brings energy in, as opposed to wandering around in the malaise. And how it shows up with me is sometimes I just feel like throwing myself on the grenade and say, just give it to me and get it over. And I know that's not the way to do it, but it's a challenge for the community. And I only bring that up just as a context for each of us to recognize that's where we are, whether we're a frontline provider or not. And then imagine what it's like for those who are on the front line trying to improve the system, do the work we're dedicated to here on the council, respond to COVID in a respectful and responsible way, and then have our own stuff on top of that. So it's a small thing that you guys have been facing into. So the original question that caused me to raise my hand is that the ops committee, from my perspective as an outsider, never having participated in a meeting, is where the rubber meets the road. It's where the real stuff and the gnashing of the teeth and the successes really begin. And you guys deal with issues every month, and the members that are on the committee assure me that that work is done, and I believe it and I trust it. However, sometimes I think that there are things that you learn that might be helpful for the non-participants to know, so that as the board is asked to make a decision, we're aware of those policy issues or that context, so that we can make a better informed decision. And so respecting the need for privacy and safety and that everybody can't be on this committee, I would invite the committee chairs to think sometimes about that as you're going through your own discussions. What have we discussed today that might be really helpful for the entire board to know, to equip them to be better decision makers, just from a government?
Yeah, that's a great thought. I think that's something that Emily and I could add to our discussions with, because we do an agenda planning meeting with our COHC partners, and that would be a good opportunity to identify things we want to carry back to the board.
Yeah, I love that idea, Linda. Thank you. We can absolutely do that. And I just wanted to add one thing to Janet's response in to Divya's comments, where I think that the workforce issues and the burnout that we see happening is also a call to action to align our larger systems to work together towards the same end. And so we are looking at understanding, socializing how the regional health improvement plan overlaps, and the measures in there, the goals of that overlap with the goals of our CCO measures. And I think that's a really important intersection, because we can start to see exponential gains in both areas if we're thoughtful and strategic enough to design the work with both of those things in mind and finding the points of synergy. So, I agree with everything we've said about the need for a workforce. I also hope it pushes us to think about how to redesign or rethink some of our systems to have better alignment, perhaps. Is there any other questions? That is what Janice and I had for you today, but happy to take any other questions now or after the fact. Michaela can find us. I think many of you have our emails as well.
I'm not seeing anyone raise their hand, but let me just say thank you both so much for the work that you are doing and for providing hope during a time when it really is feeling pretty darn heavy. I'm making decisions based on this these days. And so if anyone wants to borrow it, They're really short and sweet, and about as accurate as many of us are making these days anyway. So just really want to say thank you for the commitment, the passion, and the dedication, and for being with us here today, and for what you're doing for our community as well. So thank you.
Absolutely. Thanks to all of you. Thanks for having us. Bye-bye.
Bye.
Okay. And I'm going to start renting it out. So if anybody wants to, we can pass it around. Next on our agenda, we have the CAC report. So I'll turn it over to Brad and Linda.
Thanks, Tammy.
Yes.
Okay. This isn't entirely comprehensive, but I want to give you guys kind of a rundown of what we've been up to and some things accomplished in the past year. Again, it's not comprehensive, but it'll give you a good idea. So our membership, we had 3 consumer representatives move on from the CAC, Trey Madden, Jolene Green, and Chris Woodard. And we had 3 join us, Myra Benitez, Connor Carlson, and Stacy Shaw. We also had 3 other members join, Regina Sanchez, Cook County Health Department, Miranda Hill, Klamath County, and Natalie Chavez from Jefferson County Health Department. Something else we've done is we're switching up our meeting culture, which is kind of, toning down the Robert's Rules lingo and making it less formal and institutional, and also trying to have it be more conversational and less presentations being presented to us, having more conversation, using plain language. And we're also spending 10 minutes to start each meeting in breakout rooms, just getting to know each other. Those are some things we've been doing as far as the meeting culture and just kind of working on our the time we spend together, making it meaningful and enjoyable. Some other things we've accomplished and are working on. We have funded 10 projects through the Community Health Projects process that address social determinants of health and health equity. And those 10 projects have received a total of $687,334. And we're in the process of awarding another $61,432 of residual funds that came our way. So a couple more projects will get some funding in the next couple months. We've been working through emerging issues. I think the board is aware that we've developed an emerging issue process, and we've been working through our first couple of emerging issues through that process. That process looks a lot like this. An issue is identified. The issue is assessed to understand the scope and the system level implications, whether or not it's something the CAC can actually do anything about. The CAC works with our Pacific Source and Oregon Health Authority liaison to find support for the impact, if there's impacted individuals specifically, and to work on system level improvements if that looks like the way we want it to go. Issues may be brought to Oregon Health Authority, Pacific Source, or the board. The current issues we're working on are periodontal care, dental care, specifically pediatric dental care, and chiropractic services. Those are our 3 current emerging issues. And we're happy to report that there has been progress made and on individual issues. And we're also looking to schedule a panel discussion with the dental care organization representatives, a combined DCO CAC meeting in March, April, sometime around there. So we're excited about that. So we get to kind of have a back and forth, learn more. The CAC members can learn more. We can share experiences and have a productive dialogue there, and maybe get some system improvements made if needed. We are in the process of electing a co-chair, vice chair. We'll be doing that at our next meeting. Larry Kogosik was vice chair for ages and ages, and he moved on a couple months ago, or maybe a few months ago, just really buried with all the demands that COVID has brought to his world, all the good work he does in the community. let's see, grievance and appeals inquiry. We asked Pacific Source, please let us know what's going on with grievance and appeals. So one of the things about the advisory council is we have, I think, 9 community representatives. And, that's fantastic, but we can't possibly speak for the broader community, the 3 counties and beyond. So, we're looking at ways to better understand, what Pacific Source is hearing from consumers and see if there's anything there that we need to give our attention to, bring to the board. What does that look like? And finally, we did receive lots of presentations, of course, from Pacific Source, the health equity plan being the one that comes to my mind immediately, but there's been several, including on grievance and appeals. And then, of course, we're making progress today with strengthening our relationship with the board of directors. So welcome to all of our Community Advisory Council members, and thank you to the fellow board members for being open and excited about doing this.
Excellent. Thank you, Brad. Any questions for Brad or comments? That's a lot of work and a lot of involvement, which we just couldn't do without the investment of time. So really excited that folks are participating and with us here today as well. So any questions? All right.
Linda,
oh, Linda, right ahead.
Yeah,
Please.
I just wanted to make a comment of how much fun and how rewarding it's been to see this shift in the committee over the last year to year and a half as it looks inward and looks at how it wants to become stronger, more powerful, more effective in its relationship with the board. And also, things like the issues identification process, how we've selected new members, all being trained and educated to be able to give grants and to feel comfortable and confident in that. And to see just the quality and the development of the people on the committee is really delightful to me. And I give Brad and staff total credit for that. It's been really rewarding. And I look forward to today's meeting as the board continues its own internal work of how can we work more effectively with CAC, be clear about what our needs and expectations are as CAC does the same.
Love it. That's an excellent tee up for our next part of today's agenda, the exciting part where we get to have an opportunity to be together as the CAC and the council. So unless there are any questions or comments for the general meeting, I'll give just a quick pause. If anyone has anything that they want to state before we peel off. Okay. So let me thank those that are not part of the CAC or the council board for your time, and we wish you a joyful day and look forward to seeing you next month. And for the rest of us, let's go ahead and just take, shall we take a 3-minute quick break? I'm seeing some heads nod, maybe a quick, and then is there anything we need to know when we come back, Donna? Go right ahead. Yes.
So we do need to formally adjourn the board meeting, please.
Okay. So unless there's anything to add, I will formally adjourn the meeting. And hearing none.
Second.
Oh, there. Thank you. All right.